Chapter 16 is on schizophrenia, and you guys may have kind of noticed if you've been on clinicals for mental health that the DSM-5 and the DSM-4 diagnostic criteria in terminology has affected schizophrenia. So if you have happened to have a patient diagnosed with schizophrenia, or like paranoid schizophrenia or disorganized schizophrenia or anything like that, those have all now been grouped into just schizophrenia. So we see even now in practice that they still haven't went to the DSM-5 and just labeled it schizophrenia. So if you do have any of those patients on the clinical site like that, just label it schizophrenia and just do your patho and everything on just schizophrenia. Don't worry about the paranoid or disorganized or anything like that. So schizophrenia, it's thought of as a system or disease process with many different varieties and symptoms. It affects thinking, behavior, emotions, and the ability to perceive reality. And many people today that have schizophrenia, they're able to live within the community thanks to the new atypical antipsychotic medications and the community-based treatments options that are out there now as well. The onset of schizophrenia is usually later teen years to early 20s. Rarely is it seen in children, but it could be. They have to make sure to rule out ADHD with violent tendencies before they can get the diagnosis of schizophrenia. And it has to be after the age of 7. Symptoms of schizophrenia, they are known as the positive or hard or the negative and soft symptoms. There are medications that will treat just the positive, and there's also medications that will treat both the positive and negative symptoms, which we will talk about a little bit later. So let's first just talk about the positive symptoms. These are manifestations of things that are not normally present, okay? And these are the most easily identified symptoms. So let's start off, let's talk about associative looselessness and flight of ideas. So these things, they may seem kind of similar whenever you read the definition, but there is a difference. So the associative looselessness, this is a disturbance in thinking in which ideas shift from one subject to another in an unrelated manner. So there's a key word. And these thoughts are often difficult and you're not going to be able to follow them. So an example would be if a patient says, I got a cut and I need a Band-Aid, and then goes into, my friend was talking about AIDS, how can you trust the French? They won't let you take pictures of the menu at McDonald's. So none of that has any relation at all, okay? And then we go to flight of ideas. Now this is the continuous flow of speech in which a person jumps rapidly from one topic to another, but usually the topics somehow can be related to each other and you can kind of understand. So an example would be, he's wearing a yellow shirt, bananas are yellows, my husband likes to eat bananas, my husband brought me a dishwasher. Okay, so you can kind of follow where the yellow shirt reminded her of a banana, which reminded her of her husband, which reminded her that her husband bought her a new dishwasher. Delusions, there are false beliefs that something is going to happen. Echopraxia is whenever the patient mimics movements that they have observed. Hallucinations are false sensory perceptions. They believe something is currently occurring. In the idea of the reference, we talked about this in Chapter 8, your assessment chapter. So if you have any questions on any of these, make sure you go back to Chapter 8 to look at that. The idea of reference is patients, they have an inaccurate interpretation that general events are personally directed to them. So that's whenever they believe that the person on TV is talking directly to them or telling them a message. That's kind of an example of that one. Bizarre behavior that they might exhibit is they could be walking backwards constantly, pacing, walking, their clothing may be unmatched or not correct for the current season. So if it's summertime, they may have a big heavy coat on. The negative or the soft symptoms, these are the absence of things that are normally present. Okay, so the aloga, this is where they don't talk much. The anhedonia is whenever they feel no joy or pleasure with any activity. Blunted affect, showing little or slow to respond facial expression, or the flat affect, which is showing no facial expression. And the catatonia, this is when a person will move very little or not at all. Remember the waxy flexibility we talked about in the assessment chapter as well. This is usually seen in patients with catatonia. It's where you can hold them in a certain position and they will keep that position regardless if it's comfortable or uncomfortable for the patient. Abolition is the reduction in motion in spontaneous activity. So basically, they don't initiate social contact, such as calling people, or they don't want to use social contact, or their ADLs are lacking as well. And then also inattention. So the diagnostic criteria is first they have to have 2 or more of the following for a significant portion of the time during a 1-month period. So that's, they have to have 2 or more of the hallucinations, delusions, disorganized speech, grossly disorganized or canotype behavior, and then negative symptoms as well. So they have to have both positive and negative symptoms to be diagnosed with schizophrenia. They also have to have an impairment in school or work, self-care, or interpersonal relationships. They will have psychotic thinking or behavior present for at least 6 months. In the schizoaffective, depressive, or bipolar disorders with psychotic features, they have to be ruled out as well. And also ruled out is substance abuse and medical conditions that could mask schizophrenia. So those all have to be ruled out before schizophrenia can be made. So the theory of schizophrenia. They think that due to excessive levels of dopamine and serotonin are thought to be the cause of schizophrenia. Just remember serotonin, it works in the body, basically just kind of help you feel better, and dopamine works by rewards and motivation, kind of wanting you to do things. Make sure you read over this assessment part. We went over quite a bit, but just talking about positive, negatives. All right, so delusions. Delusions, remember, are a false belief something will happen. Then there's different types of delusions. Paranoid delusion is a common one. They believe others are planning to harm the patient, or they're spying on them. Grandiose delusions. The patient claims to have an association with a famous person or a celebrity. Another common one would be religious delusions. Basically just kind of obsessed with religious beliefs, may claim to be Jesus, or they may claim to be a prophet with special religious powers as well. For hallucinations, this is a false sensory perception. The auditory is the most common. This is where they hear voices. So the voices can be also command hallucinations. It's where they are demanding the patient to take action or to harm self or others. And whenever these hallucinations become command hallucinations, we have to remember about patient safety. So not all auditory hallucinations are command hallucinations, but they can have command hallucinations, and we need to make sure that we think about safety, not only for that patient, but for also for what those commands are telling that patient to do against other people as well. Visual is the second most common. This is where they see a person, animal, object, etc. that's not there. Then they can have hallucinations such as smelling odors or tasting. The tasting one, they may say that they taste the poison in the food. And if you have a patient like this who refuses to eat because they think the food is poison, then the best thing that you could do is just take them to a vending machine and let them get their own food that has already packaged, and so they know that you can't put any poison in it. Let's see, another one would be the tactile, just when they feel strange sensations on their skin, such as like bugs crawling on them as well. So continue to read over the assessment. Refer to chapter 8 if you need that. Any clarifications? Goals. So if you have a patient that is in the psychotic phase, the goals would be based on basically safety and just establishing contact and reality for that patient. So nursing interventions when caring for a patient with schizophrenia. Safety, that's the main one. Okay, we want to think not only about the patient for those around, but also the nurse, the aides, the other patients, etc. So what I kind of hit on earlier about the command hallucinations. If you have a patient with the command hallucinations who are telling a patient to kill their roommate, that will heighten your safety measure. Okay, so if this will happen, you would need to put the patient that is experiencing the command hallucinations on a one-on-one observation and move them out of the room and make sure that they are not sharing a room with another person. It's important to establish your relationship and use your therapeutic communication still. When a patient is experiencing hallucinations, you want to approach them in a non-threatening, non-judgmental manner and focus on what is real and help the patients focus back onto reality, and never argue or never agree with the hallucinations either. So you can say something such as, I don't hear anything, but you seem frightened, or I understand you hear a voice, there's no one else in the room besides us, I don't hear the voice. So that you're showing them, okay, that you understand, but then you're still presenting reality. You're understanding how they feel, but then you're presenting reality back to them. When a patient is experiencing delusions, again, we don't confront or argue with the patient, but acknowledge that the patient is having this experience, convey empathy about the fears that they are having. So just the example here, the patient says, you people are all alike, all in on the FBI plot to destroy me. The nurse would then say, I don't want to hurt you, Tom. Thinking that people are out to destroy you must be very frightening. And to put the patient's name into it is better, because that is bringing them back to reality, that they are talking to you and hopefully getting them out of the delusion. So, we can use distraction techniques as well whenever a patient is experiencing hallucinations or delusions. Is it difficult for the patient to pay attention to the hallucination or delusions whenever there are reality-based activities going on at the same time? So just have them, like playing cards, watching TV, have them talking to other people, getting them up, walking around, getting them distracted, telling them to go to the gym if they start to hear these thoughts or voices. We could teach them that if they start to hear these voices, that they can look around and see what other people are doing, and if they don't feel the other people aren't portraying that they are hearing or feeling frightened or afraid, then they know at that time that those voices are not real. Just make sure we use I comments and not you comments, just like any other time. Read through these as well. Review the family education and early signs of relapse. Those two. So your antipsychotic medications. Medications are used to manage the symptoms of schizophrenia, they do not cure the disease. So there's two generations. There's the first generation and the second generation. The first generation is the conventional antipsychotic drugs. They work by decreasing the amount of dopamine by blocking the dopamine receptor. So remember the theory that schizophrenia is caused by increased dopamine and increased serotonin. And so the first generation works by blocking the dopamine receptors. All right, so the first generation, they only work on the positive symptoms such as your hallucination, your delusion, your bizarre behavior, associated lucidness, and stuff like that. Some examples, common ones are your Thorazine and your Haldol. These medications are not given as much now since the newer atypical or your second generation drugs have came on the market. Due to this generation, they cause more of the extrapyramidal side effects. Look, there's a slide on that, so make sure you read over those as well. So this first generation, we don't see that given quite as much because of the EPS. The atypical medications not only diminish the positive symptoms, but they also lessen the negative symptoms. And they work by blocking less of the dopamine receptors than the conventional antipsychotic drugs, which is why there is a decreased risk for EPS. And they also block the serotonin receptors. So remember, schizophrenia is thought to be a result of an increase of dopamine and an increase of serotonin. Oh, there's medications, Clozaril, Risperdal, Seroquel, Zyprexa, Abilify, those are all common second generation. Make sure you read over these next few slides on adverse reactions. This should not be new information that you probably already had in Pharm. Clozaril, they bring this out, and it's important to remember that it can cause the aneuglycocytosis, which is basically you don't have enough white blood count. So any patient that started on this, they're going to have to go in and have blood work drawn weekly throughout treatment, and then once they determine that it's not going to affect them, then they'll be able to go and have blood work drawn about every 2 weeks to a month. Just kind of depends. Now, pharmacy, this one's a medication that pharmacy will actually probably need or probably request from the doctor's office a white blood count prior to filling this medication, just because of this side effect, which is probably why it's not prescribed real often, just because of the non-compliance that may be occurring, not with having to go and get the blood work drawn so often. Physicians will probably only prescribe this for a week to 2 weeks at a time as well.